Hi, my name is Eric Curtis, and I'll be resuming my musculoskeletal assessment, finishing up with the hip assessment, and then moving on to the abdominal assessment for nursing 383. I'll just pick up where I left off. Previously, I washed my hands, I introduced myself to the patient, performed the general overall survey, as well as the upper and lower extremity assessment. Moving into the hip assessment, with the patient's hips exposed as necessary, we note any obvious joint deformities that may be present, skin lesions and such. We'll apply some direct inward pressure bilaterally on the hip joints, noticing, feeling any signs or any presence of any clicks or crepitus that may be there, while observing the patient's nonverbals, any grimacing or guarding that may be a sign of pain. Moving on to range of motion with the hips, we'll start with one leg. We'll just lift it slightly. While palpating the hip, we'll do an adduction and then an abduction. And then on the opposite side, we would do the same. While palpating, we'll do an adduction and an abduction. And then bending the leg upwards at about a 90, we'll do an adduction and abduction. And then the same on the opposite side. Adduction, abduction. And while palpating the hip joint through those ranges of motion, it gives you a good sense if there's any clicks or crepitus or anything going on inside that joint. That concludes the musculoskeletal portion of the assessment. Again, range of motion was all within defined limits and would be given a score of 5 out of 5. Moving on to the abdominal assessment then. Again, we would typically have the abdomen exposed for direct visualization. We would note any abnormalities in the skin color, presence of any obvious masses, peristalsis, pulsations, note any surgical scars that may be present, and inspect the umbilicus for eversion, inversion, and skin color within the umbilicus. So then at that time, we'll have the patient place her chin on her chest, take a deep breath in, and exhale. And while we're observing for any masses that may become present at that time with that position change, any hernias that may be present, or muscle separation. Moving forward with the exam, we'll begin with auscultation, and we'll start our auscultation in the right lower quadrant with the diaphragm of the stethoscope. And we're listening for tinkling or gurgling little sounds. Typically, about every 5 to 15 seconds would be normal bowel activity, and we'll do all 4 quadrants systematically, noting presence of bowel sounds in all 4 quadrants. In the event of absent bowel sounds, it would be important to listen to each quadrant at least for 5 minutes in each quadrant prior to declaring absent bowel sounds, indicating a potential ileus of such. At that time, we will then auscultate the aorta with the bell. In the epigastric midline area, again noting presence of any bruise that may indicate a stricture or a blockage of some sort. And then superior and lateral to the umbilicus, we can palpate the left renal artery. And then oppositely, we'll do the right renal artery. Inferior and lateral to the umbilicus is the right iliac artery, and oppositely the left iliac artery. And again, auscultating for the presence of a bruit, indicating that stricture or blockage in the vessel. Following auscultation, we will move on to percussion, and again we'll begin our percussion in the right lower quadrant. Typically percussing to elicit any pain, detect any abnormal differentiations in sound. Typically over the air-filled or hollow organs, it's a tympanic sound, whereas in the area of the liver and the spleen, it's a dull sound. So we'll start in the right lower quadrant again and percuss just kind of systematically up and across, and we'll take note to the sound and the changes in sound. We'll be watching the patient for any signs of pain that may be elicited and where about we are when that is elicited. Sometimes if the colon is very full of stool, then you would potentially get a dull sound in that area as well. Following percussion, we move on to palpation, and beginning with light palpation again in the right lower quadrant, palpating with one hand in kind of a little circular motion, detecting presence of any superficial masses or lesions. Again, watching the patient for any signs of pain or tenderness. And typically the bladder is not palpable unless very full. Following the light palpation, we would go with deep palpation at the two-handed method. And then you're palpating deeply for any lower masses, organ masses. You can estimate the size of the liver and the spleen somewhat with deep palpation. And again, you're watching the patient for tenderness or pain. Following the abdominal palpation, we will palpate the liver. Again, can be done for an estimation of size. So we'll start with our one hand underneath the posterior costal margin. A little upward pressure, bring that liver anterior while we palpate. And then have the patient take a deep breath in and exhale. And the liver can be palpated that way. Detect any hepatomegaly that may be present or any rigid margins in the liver. Same thing on the opposite side. Posterior costal margin, a little anterior, moving the spleen anterior. And then palpate, have the patient take a deep breath in and out. And can detect any splenomegaly that may be present at that time, as well as tenderness or pain. Following palpation of the liver and spleen, we will palpate the aorta, and about mid-clavicular on either side we would palpate, and we will be palpating for the detection of any pulsations, and then also the size of the aorta, which generally is normally around 2 centimeters. Anything greater than 2 centimeters could indicate a potential abdominal aneurysm. So we'll finish up our abdominal assessment with the palpation of femoral pulses on bilaterally. Again, we'll be noting that strength and rhythm and rate, and then symmetry side to side. Again, looking for that +2 normal rating for pulses. And then we would finish up by also palpating the inguinal lymph nodes for any enlargement, tenderness, and taking note to the degree and symmetry side to side of those lymph nodes. That concludes the abdominal assessment for nursing 383. I'll finish up by washing my hands, thanking my wife, my patient, and thank you.